So how easy is it to meet criteria right now for bipolar disorder? Well, bipolar 1 disorder is supposed to be that traditional manic followed by depressive illness, right? That's what we saw. That's going to drive the hospitalizations, the disability. It's that mania, a distinct period of abnormally and persistently elevated, expansive, or irritable mood. That's abnormal, and it can be really problematic. So
For
yes,
how long?
right. This is the new criteria. This is the DSM-5 criteria. It has to last a week. This is for bipolar 1. So 1 week, okay? Now listen, if someone is sleeping 2 hours in the process of starting a business in an area they have no expertise, giving away money, leaving their family, really impulsive actions that don't represent anything about their past, that's serious, right? And to me, understanding mania in that context and in labeling them as having manic depressive illness or a bipolar condition because we have to stabilize that episode, that makes sense to me. That's grounded in some empirical and historical evidence. What I'm just saying is that it's rare. It's just historically rare. And the drugs that we're going to use to treat it, really, they're about emergency medicine, about stabilizing that episode in the short term, not something that we have outcomes positively for long-term use of that. In fact, it's quite the opposite.
And even in the short term, you don't know what the root cause is, which goes back to the
Right.
things that we just spoke about.
You're not targeting the root cause. You're just stabilizing an episode.
Stabilizing temporarily. Let's find out what caused this.
Okay. Now, here's my case for how easy it is to be diagnosed with mania.
Okay.
It's different than the past. It's different than manic depressive illness. You only need 3 or more of the symptoms. Okay.
Only 3?
Only 3 of these 7. Okay, Sean?
Okay.
3 of these 7. Now remember, mania that creates psychosis, certainly serious. Okay. But you don't even need that to meet the criteria. So I'm going to give you the 7 symptoms, and I'm going to choose 3 that I believe are going to be widely applied to anybody at different points in their life.
Okay.
So the first one is inflated self-esteem and grandiosity. That I'm not saying is widely applied to everybody. That is something that can be representative of a manic episode, right? But inflated self-esteem and grandiosity be like, listen, I have godlike status.
Okay. There's a difference between self-esteem,
right,
and grandiosity.
Right. Like,
was it and or like grandiosity?
And, yeah.
And okay,
yep.
Okay.
I'm going to become rich.
Oh.
I'm going to start this company. I'm going to change the world. You have no background or evidence, like things like that. They really stand out. And again, that would be indicative of a manic episode.
Okay.
However, just this idea of inflated self-esteem can get really misrepresented in a checklist, and it can get misrepresented by the worst of clinicians because it's not really something that's constant. We see this all the time. Sometimes people feel good for various things. Maybe they feel like they look good. Maybe they have higher energy because they're rested or eating good foods or exercising. So it's this inflated sense of like feeling good. That is normal. Some days we don't feel so great about ourselves. Other days we can feel better. Confidence isn't just some consistent presentation that exists. So that can get misrepresented. All right. Number 2 is something that, from a checklist standpoint, now gets misrepresented as a reason for a past episode of mania. And that's decreased need for sleep. Okay. It is quite normal for people to go through periods with a decreased need for sleep, right? Generally speaking, you might be excited about something. You might be working on a project that impassions you. And maybe you only need 6 hours of sleep. Other times in your life, you need 8 hours. Certainly not in itself evidence of a manic episode. However, somebody not sleeping much at all can induce a lot of problems. And yes, it's got to be understood in context. A lot of this stuff requires investigation. Okay. Number 3, more talkative than usual or pressure to keep talking. Again, everything's on a spectrum. To what degree, to what extent, to what severity. So when you give someone a checklist, it's very easy for them to say, I'm more talkative than usual. Number 4, flight of ideas or subjective experience that thoughts are racing. Okay. Flight of ideas is one thing. A lot of people right now report thoughts are racing. Okay. Worriers have racing thoughts. You know, anxiety. Flight of ideas is different. That's like the bouncing of ideas, new things to new things. There's not always like a coherent way of following somebody. If you ever meet somebody who's manic, it's very obvious. Right? This is ridiculous. Number 5, why is it in the criteria? Distractibility.
What is it?
Distract.
Somebody jiggled their keys and I looked left.
Yeah. Everyone's distractible.
Yes.
Right. It's a human condition, so forth. For them to put that in a criteria, a symptom for mania, is just absolutely absurd. Okay. Number 6, increase in goal-directed activity.
Well, that could be a benefit. I'll go back to cleaning the kitchen. So let the person clean the kitchen and then tell them to go to sleep when they're done.
That's where it can get misrepresented.
Yeah.
You know, sometimes people just get, some energy to get things done. You know, Sunday I did spring cleaning.
Oh, there's been times where I've woken up in the morning. I'll use the kitchen as another one where I feel like it's just gotten to the point where it annoys me. So I'll pull everything out and I'll start scrubbing stuff, and then wife and kid will come down. I'll be like, "Stay out of here! I'm in the zone right now. Find something else to do for the next hour."
Yeah, and I'll do that. Like once I get it started, I'll work all day just to get it done.
Yeah,
because I don't want to stop and have to go back to it another time because I don't like it.
Yeah,
right. So I cleaned out my grill this weekend. Like
about time.
Yeah, I mean everything out, scrubbing everything, and just cleaning off the cushions for all the furniture, getting everything ready for the kind of spring summer that we do out there, cleaning everything out. And once you get started, you get on a roll, you just get it done, right?
Yep.
That can be interpreted through these checklists and through these horrible psychiatrists who are doing things in 15 minutes. Increased in goal-directed activity, check. When really these things require investigation.
Mm-hmm.
They require context. Now, number 7, excessive involvement in activities at high potential for painful consequences. All right, so this is like the impulsive
risk-taking.
Risk-taking. Now, these are the things I would want to see. Severe impairment from these activities that have a high potential for adverse consequences, significant decrease in sleep, right? High energy, functional impairment. I need to see those things. But when you go to only 3 symptoms, and you can get them from distractibility, decreased need for sleep, and increase in goal-directed activity, you can understand how easily someone can be diagnosed with a manic episode. Here's the problem. The problem is that most people being diagnosed with bipolar disorder are not being diagnosed with bipolar disorder because they're in a manic episode. They're getting it done historically. Right? So they see someone is struggling, depressed, maybe what's called hypomanic, and I'll get to that in a minute. And the doctor, these doctors in psychiatry who have been so conditioned to fear this condition called bipolar disorder, like, oh my God, if someone has bipolar disorder, they have this underlying bipolar disorder. What if I prescribe an antidepressant? Now it's going to induce a manic episode, because they have underlying bipolar disorder. And it's like one of the few things they're really quote unquote experts in the entire system is the management of this condition. So as you would expect, they see it a lot more than what it actually is. Mm-hmm. So someone comes in is just like low mood or depression. Well, they're going to ask questions and try to determine if someone has a history of a manic episode. And so what I am seeing in clinical practice is what is not mania is being assigned as mania to a large degree of people, even young people, even teenagers, where this mood instability is normal.
And not sleeping at night.
Oh my God. It's just, I can't believe what's happening out there. Okay. So you meet that criteria for that one manic episode, right? And you combine it with hypomania, any period of hypomania.
Does the manic episode have to be prolonged?
1 week.
So it has to last for a week.
Mm-hmm.
Okay. So it won't just be like you on the weekend.
No, it's got to be a week, combined with either what they call major depressive disorder or hypomania. Okay. And this is to get bipolar 1, remember. This is that serious manic depressive illness.
Understood.
So we've already seen that's easier to get assigned that manic episode. And we've talked about how easy it is to meet the criteria for major depressive disorder. That's just a 2-week period of time. And you only have to meet 5 or 9 of symptoms, right?
Mm.
And what I will argue is every human being can meet the criteria for major depressive disorder at some point in their life, right? So what is that? 5 or 9 of symptoms in a 2-week period. Depressed mood, loss of interest or pleasure, change in weight or appetite, sleep problems, loss of energy or fatigue, worthlessness or guilt, impaired concentration or indecisiveness, thoughts of death or suicide, slowing down, what's called psychomotor retardation, or agitation. So,
Thoughts of death or suicide.
mm-hmm.
What if somebody keeps saying like memento mori to you? Is that thoughts of death?
Yeah. So most humans will think of death. And so when you put it, like there's reasons why it's framed this way.
I don't think of suicide. I don't have suicidal ideation.
Yeah.
But do I think of death?
Yeah.
Yes.
But that's why it's framed.
As a reason to live.
That's why it's framed. Because you ask more people, have you ever thought of dying? Or have you ever had the thought of suicide? Well, of course you've had the thought of it.
Mhm.
Doesn't mean you're wanted to, your intentions was to do it. So that's what you do. This is diagnostic inflation. This is how you increase the prevalence rate of a diagnosis. So since everybody, if you said it to the right person, most people experience it, I'm not going to go tell a doctor about this. This is just normal, right? They just accept that this is part of living. I'm going to get through it, right? But a large portion of people aren't going to do that. They're going to go to the doctors, and now they meet that criteria for major depressive disorder. Now you can historically go back. You can easily dig up what's called a manic episode, okay?
Yeah, you also don't know what other people are thinking. So if you're thinking of death, which is normal, and then you go to a doctor and the doctor says it's not normal, then all of a sudden you start thinking there's something wrong with yourself.
Exactly, right. All right, now we start getting into where this stuff is a bit of a running joke, okay? Hypomania. Right? Hypomania is a running joke for many people who are critical of psychiatry's assault on normal. I've heard clinicians refer to this as bipolar light. Like hypomania is a core feature that has led to the astronomical rise in diagnoses of bipolar disorder, specifically with a new category called bipolar 2 disorder. Okay. Until 30 years ago, bipolar 2 was like this Pinocchio of psychiatric disorders, like long recognized and referred to as not a real disorder. But in 1994, this disorder was finally given recognition in the DSM, and it's called bipolar 2. And do you know who was the chair of DSM-4?
I do not. Was his first name Alan?
You do know it.
Oh, okay. I just didn't know his last name.
Yeah, gentleman's by the name of Dr. Alan Francis.
Yes, there it is.
He's kind of well known now because he's speaking out against the assault on normal from his field in psychiatry. But I loathe this guy because I find.
Well, I'm on a first name basis with him, so
I find him disingenuous, right? Because he really had the ability to curb this. He was in a position of leadership. In 2020, he tweeted this out. I greatly regret adding bipolar 2 to DSM-4. We had good reason to reduce iatrogenic switches, rapid cycling, and spectrum patients due to antidepressants. So right there, he's kind of acknowledging that antidepressants induce a mood dysregulation.
So they shouldn't be over the counter, as some people are now recommending.
That's ridiculous, right? But it led to it's a myth, right? You can achieve bipolar 2 by this, okay? 1 major depressive episode in your lifetime, okay? Which I've already said can be applied to anyone if you want to frame it that way. And then 1 or more hypomanic episodes. So I said that hypomania is like bipolar light. So like what does that mean? Like what is mania light? Like hypomania? A little bit more irritable?